Okay, let me say right up front, I'm absolutely not a fan. I said I'm not a fan of having a radial type heart catheterization procedure. I'm just not a fan of them going through my wrist. And I thought I'd take a moment or two today to explain why. I actually had someone who saw me posting on someone else's page last night when they'd had one to go bad, that I never allowed them to do that I just didn't like them. And they in turn messaged me and said, why is that the case? They had had a few that have gone very smoothly, and they want to know why I chose not to do that. Now, before we get into that, basically there are three types of procedures that are often done post-heart transplant when it comes to your catheterization / arteriogram / biopsy type procedures. And it basically all only changes according to where the access point is. In general, all three of these types of access have basically the same risk. Okay, the top risk is going to be bleeding. Second to that may be clotting. And third to that may be injury of the vessel, vein, or artery that is involved in that. That's just a risk that is always there. It's a chance you have to take, but these procedures are extremely important to us post-transplant, so it's kind of a risk versus benefit situation. Yeah, that's how it goes. That's just part of being a transplant recipient and the wonderful gift that we have received as a result. Now, again, those three types or access points come down to number one, most common, the femoral artery. And that's the artery down in your leg, so up in your groin area. Typically speaking, they can go through the femoral artery. The benefits of going through the femoral artery, number one, is ease of access. That artery is pretty huge, and so the access is easy there. There's usually not a difficulty in finding that particular artery, tracking it down, getting all the sheets and the cats themselves and any other devices they need to use to take view of your pressures and or just take biopsies or whatever. They can generally do that fairly easily through the femoral artery. Another benefit to that is at that particular access point down here, they can either go for a left or a right or both left and right heart cath through that same access. And that's great. And that's something that really, for me, makes that the better way to go about things. And that's why I typically always vote, hey, if you want to cath me at all, go through the femoral artery. That way we can get everything done that we need to do through the femoral artery. They can also do balloon type procedures. They can install stents. Anything that they run into during the procedure or anything that they may need to treat through a catheterization type procedure anyway can be done through the femoral artery. Again, number one thing there, ease of access. Now, as far as the risk, they're the same for all. Bleeding, however, is a little bit more highly concernable in the femoral artery because, again, you're accessing a very, very large artery in your body, so you have to be a little bit cautious with that. Now, post-femoral artery catheterization, you're probably going to be asked to lay flat of your back or nearly flat of your back, just a little bit of elevation there, for approximately 3 to 5 hours. And I've been there as long as 6, and it's not very comfortable to lay in that position. Now, through the years, they've changed the method by which they do that. In the beginning, what they do with me, they lay the old classic sandbags on my leg. They hold pressure with their hands for about 20, 30 minutes, and then they lay sandbags on there, and you lay the whole time with the sandbags. You can move, but not that leg, and it's just a lot too. Again, you're laying flat. It's not very comfortable. Since that time, they've gone a little bit farther, which has helped a lot. They've cut my recovery time down to about 3 hours through that access by using basically a wad or roll of gauze, and then they've got some elastic rubbery style tape that they tape around there, and that keeps that pressure on it consistently. You don't need the sandbags. You're still not able to move. The only problem that I have with that is, as far as Gump would say, that tape goes all the way around to the buttocks, and it's not very comfortable. Tapes typically kind of leave blistering on me, and you can just imagine it's just not fun, but it is one of the better methods. In addition to that, they have started doing, on occasion, they'll plug that artery, which is a good method. There are a few problems with that I'll mention in a moment. They'll plug the artery. That gets you out of there slightly quicker. They have used in the past a little balloon type thing that they actually air up with a syringe, and that'll keep that pressure. I don't like those because those being rubberized, they do rub, and they do cause blistering at the site. So I don't like those. I'd assume the water gauze and the tape over anything else. But that's the types of things that they do. Now, I mentioned the plug a moment ago. The plug is great. The plug can have you out of there in an hour and a half or maybe 2 hours, shortening that time up quite a bit. But with the plug, if you read your instructions carefully, what the plug will actually tell you is that after you get home, you're supposed to take it easy in general and not lift a lot of weight for up to 30 days, okay? The other instructions for the other methods may say up to a week, 30 days for that plug, because that plug not only has to slowly dissolve in there and it heal over, and in my mind, it just kind of slows the process of it closing. Yes, it gives you that immediate get out of bed and go home thing, but you have to wait on the plug to dissolve for it to actually close. So, yeah, ifs or theirs. I generally say no to the plugs, and I go with the classic tape and gauze. That usually works best for me. That's the femoral artery. Again, that's my favorite type. Now, as far as the next level of that, this is what you'll have most commonly immediately after your heart transplantation. They're going to go through the carotid artery in your neck. Now, this has a lot of benefits to it. For one, it does give them access to the right side of your heart, which is typically where they take all the pressures, all the biopsies, all the things that they need are accessed there. You don't have access to the left side going in through that carotid artery, only to the right, so it's a little bit limited there. But they are able to get good numbers, good pressures available from that, and certainly to easily do those biopsies. And you can see physically there that the the catheter itself can be much shorter, because the distance between here and, of course, the heart is, for me, like 9-10 inches probably. Not literally, you got to make a few curves, but much shorter than going up through the femoral or the leg. But you might have that most likely after your transplant, because that's the one that they're going to go in for quick access when they're doing those biopsies, maybe weekly or bi-weekly in the beginning, and it just gives them good numbers. And I don't mind that one. The downsides with that one, of course, bleeding, although much less than the femoral, clotting and the same injury procedure there, but or a risk, I should say. Generally not an issue for me. I've never had any problem on that. As far as the thing I don't like about it, I can actually visually see out of my peripheral vision. I can see the catheters coming in and out. And so unlike the other procedure where there's a curtain up, I can see it, and just kind of the sound sometimes of that catheter zipping in and out can be a little grating. But they typically will give me something to relax me a little bit, so that's not that much of an issue. But that's kind of one of the procedures that I'm willing to do, although I still would vote for the femoral over the carotid just because they can get everything done in kind of one shot. Now, the last one here is the one I said in the beginning I do not like, that radial arterial procedure. Now, to go in through the wrist, you can obviously see if the distance here is the shortest, this is mid, going through the wrist is quite a bit of ways to travel. I'm over 6 foot tall, so going from here all the way down my arm, back up my shoulder, down into my chest wall and into my heart, that's a pretty good ways to travel through that radial perspective and that access, and I'm just not a fan of it. Now, a lot of people sing the praises of it. For one, it's a much smaller artery, so there's a little bit limited access there, but it's much smaller. It's therefore safer. There's less risk of bleeding, that sort of thing, and they really like the recovery, because where this femoral might be 3, 4, 5 hours, up at 6, carotid may be about, say, an hour or 2. This right here can be almost within minutes. I mean, basically, they pull you up off the bed. They put a bracelet type thing that they tighten down over that radial access point. And if you're not bleeding within a few minutes, I've heard people say as short as 30. Now, I think about an hour would be more accurate, but I've heard people say as short as 30. If they're not bleeding, they send them home. What I don't like about it, one is the access is limited. They can't do as many procedures and see as many things. They can't measure the pressures in the same way. It's just a little bit different access there. But the thing I don't like about it is the bruising and the pain that comes in with this one. Yeah, sure, this one here had some pain, so did the femoral, but this radial, to me, I can't stand that. As a matter of fact, if they go to place even as much as an IV in me, I tell them, you can put the IV from my elbow to about 3 or 4 inches down, but I will not allow anybody access to my wrist or my hands. I just don't like it. I've had too many of those things blow out and the pain involved. And, you know, when you get home, think about it or not, your neck really right here, it doesn't move very much. So there's not a lot you're going to do with that neck. Even your leg, even though you might need to walk and you have to take it easy for a day or two, that's just not a lot of pulling that's involved in that. But when it comes to the wrist, it's unbelievable what you need to do with your hand. In this case, it'll typically almost always be your right hand. There are things that you need to do to take care of, and this going to hurt. As I say in my house, that's going to hurt like a monkey butt in some cases. And I've heard people report that it's been bruised and swollen and different things. And actually, the one I was commenting on last night, actually, there was a clot that was thrown by going in that. And then ultimately, they discovered that there was actually some damage to that radial artery. So they're not even sure what they're going to do with that. I know that's all a matter of preference and opinion, sure. But those are the three main access points: the femoral artery, the groin, the carotid artery of the neck, or the radial artery through the wrist. And you're free to choose anything you want. But I would take the advice of my team and see what they're most comfortable with and whether or not they can get all the numbers and figures and pictures that they need. And then I would kind of go with what's more comfortable for me. Yeah, you can get out of the hospital real quick with that. But if you're left with a sore wrist for a month and a half, I don't know that you're really ahead of the game. You just have to be careful. Now, this has not been comprehensive. I've got other videos about each of these that you can check out that'll give you a little more detail as far as the types of things you need to watch out for. But this is kind of just my opinion in my moment, right? Till next time, folks, stay stronger, my friend.